When a patient presents to the emergency department with chest pain, the overriding primary objective is rapid triage. We have to immediately separate stable presentations from hemodynamically unstable emergencies. This flowchart outlines the baseline protocol. Every chest pain patient requires an immediate assessment of vitals for hemodynamic stability, venous access, and an initial chest X-ray. Two actions are non-negotiable within 10 minutes of arrival: obtaining a 12-lead ECG and drawing baseline troponin levels. Provided the clinical evaluation shows a low risk for aortic dissection, aspirin must be administered immediately during this initial window. The right side of this pathway highlights a critical diagnostic reality. An initial non-diagnostic ECG does not rule out acute coronary syndrome. Ischemic changes evolve rapidly. If initial findings are negative, serial ECGs and troponin monitoring become mandatory to catch delayed elevations. The first 10 minutes of triage are about excluding fatal mimics and establishing a baseline to track evolving ischemia. They are rarely about confirming a definitive diagnosis right away. Moving from acute emergencies, we evaluate stable ischemic disease. This presents as new exertional chest pressure or dyspnea in patients with known risk factors. This algorithm uses pretest probability as the absolute gatekeeper. Low probability patients receive no additional CAD testing, avoiding false positives. Conversely, high probability patients bypass diagnostic testing entirely, proceeding straight to pharmacological therapy or direct coronary angiography. That leaves the intermediate probability pathway. This is the only clinical cohort where stress testing is formally indicated. Diagnostic testing is only deployed when the results will actively alter patient management. For stable CAD, that mandate only applies to the intermediate risk group. Once a stress test is indicated, the baseline default is the exercise ECG. However, this requires a normal resting ECG and the physical capacity to actually reach a target heart rate. This matrix details physiological constraints. If a patient has a left bundle branch block, pacemaker, or cannot exercise, a pharmacologic stress test using adenosine is mandated. However, for patients with reactive airway disease, like asthma, the algorithm specifically mandates dobutamine stress echocardiography. Prior to any of these tests, certain medications must be cleared from the patient's system. As shown, beta blockers, calcium channel blockers, and nitrates must be held for 48 hours to avoid masking ischemic signs, unless testing their specific efficacy. Selecting the correct stress test requires navigating a patient's existing physiological limitations to ensure accurate results and prevent dangerous respiratory side effects. Acute coronary syndrome classifications are dictated strictly by ECG findings and cardiac biomarkers. A STEMI requires ST segment elevation in contiguous leads or the presence of a new left bundle branch block. If ST elevation is absent, the diagnosis hinges on troponins. Elevated troponins indicate an NSTEMI, while negative biomarkers classify the event as unstable angina. Initial medical management uses a conservative approach to oxygen, reserved exclusively for patients with documented hypoxemia below 90% saturation or visible respiratory distress. This table outlines the standard pharmaceutical load for ACS: aspirin, systemic anticoagulation, and high-intensity statins. Nitrates offer rapid pain relief, but require caution with hypotension. Beta blockers limit oxygen demand, but must be withheld if the patient shows cardiogenic shock, bradycardia, or acute heart failure. For patients with an NSTEMI or unstable angina, P2Y12 inhibitors like clopidogrel are frequently held until after angiography. If the imaging reveals complex coronary anatomy, the patient may need urgent bypass grafting, and active antiplatelets would cause severe surgical bleeding. The initial medical response is a delicate balancing act. You have to halt thrombus expansion while avoiding sudden cardiovascular collapse triggered by drug contraindications. Right ventricular myocardial infarction presents a distinct clinical challenge because its management requirements diverge from standard ACS protocols. This typically accompanies an inferior wall MI. The classic diagnostic presentation includes hypotension, elevated jugular venous distension, and clear lungs, frequently paired with bradyarrhythmias and ST elevation in the right-sided V4R lead. The core physiological vulnerability here is preload dependence. The damaged right ventricle relies heavily on venous return to maintain forward blood flow. If preload is artificially reduced, cardiac output drastically drops. Because of this strict physiology, medications that reduce preload, specifically nitrates and diuretics, are absolutely contraindicated. Applying standard left-sided heart failure protocols to a right-sided infarct causes catastrophic hemodynamic collapse. The correct intervention to maintain output is cautious IV fluid resuscitation. For a STEMI, reperfusion is governed entirely by the clock. The absolute rule is primary percutaneous coronary intervention, compressing the plaque with a stent, within 90 minutes at a capable facility, or 120 minutes if transfer is required. If a capable facility cannot be reached within that 120-minute window, the fallback protocol activates. Fibrinolysis is mandated immediately, assuming no absolute bleeding contraindications. Here is the critical algorithmic divergence. Patients with an NSTEMI or unstable angina never receive fibrinolysis. Clinical data shows it worsens outcomes in these populations. Instead, the NSTEMI pathway relies on clinical risk stratification using the TIMI risk score. Intermediate or high-risk patients are scheduled for early angiography within 24 hours. However, emergency triggers like hemodynamic instability, heart failure, or arrhythmias mandate immediate angiography. STEMI reperfusion is dictated entirely by a ticking clock. NSTEMI reperfusion is dictated by patient stability and clinical risk. Following stabilization, every post-MI patient begins a strict secondary prevention regimen. This table lists the mandatory pharmacotherapy, dual antiplatelet therapy, beta blockers, high-intensity statins, and ACE inhibitors or ARBs. This diagram highlights the specific role of ACE inhibitors. Over weeks to months, angiotensin II causes the damaged myocardial wall to stretch and thin out. ACE inhibitors block this process, directly inhibiting infarct ballooning and long-term left ventricular dilation. If a patient has a reduced ejection fraction combined with heart failure symptoms or comorbid diabetes, a mineralocorticoid antagonist like spironolactone is added to further suppress adverse remodeling. This pharmacotherapy must be paired with aggressive lifestyle interventions, specifically cardiac rehabilitation, absolute smoking cessation, and tight glycemic and blood pressure control. Surviving the acute occlusion is just the initial hurdle. Long-term secondary prevention exists to stop the remaining viable myocardium from chemically remodeling itself into chronic heart failure. When the necrotic tissue is weakest, the heart is vulnerable to catastrophic mechanical failures. These are categorized strictly by the timeline of their appearance, starting with the highest risk acute window, 3 to 5 days post-infarct. In this 3 to 5 day window, papillary muscle rupture can occur. It presents rapidly with a new, severe mitral regurgitation murmur, sudden pulmonary edema, and profound cardiogenic shock. Also in this time frame is ventricular septal rupture. This creates a left-to-right shunt, diagnosed by a new hollow systolic murmur and a measurable oxygenation step-up inside the right ventricle. Finally, free wall rupture occurs in this same acute period. It leads to blood pouring into the pericardium, causing sudden cardiac tamponade, pulseless electrical activity, and rapid collapse. Shifting to the LEAT timeline, weeks to months after the initial event, we find the left ventricular aneurysm. As noted here, this presents with persistent ST elevation and deep Q waves long after acute ischemia resolves, often leading to heart failure or mural thrombi. The clinical presentation of post-infarct failure is inseparable from the timeline. Identifying the specific interval between the initial occlusion and the onset of new symptoms allows for the precise diagnosis of the underlying mechanical pathology.